Thank you very much indeed. And the nice thing about being sat here is actually I don't know whether you unmute me or not at any point, so I could genuinely be sitting here talking to myself, or actually to a coat stand is what I normally do. Well, Lisa doesn't fall asleep, which is quite good. Anyway, thank you for listening tonight. At the end of a probably long Tuesday for everybody, we're going to be going through. It's probably now a very traditional ferret topic of adrenal disease, but it's certainly still relevant. We still see a lot about it. And from our phone advice line, we get a lot of queries about this still. So I guess it's still being seen by a lot of people. Okay, the problem is rooted in the way ferrets reproduce. And essentially, ferrets are fairly solitary creatures. I've kept ferrets, and nobody's kept entire ferrets to know that there's probably a good reason for them being solitary, because they are somewhat smelly. But that's also part of what they do. And what we've got to do, essentially, we're living on their own as sole carnivores, is they've got to make the most of the encounters they have. They are seasonal breeders, and they're monoestrous. So the gills will come into season with the light cycles in spring. So as the daylight hours start to increase, so melatonin will decrease, and she'll start to come into season. She'll stay in season until she's mated. And they're induced ovulators, so they have a very rough mating when they do mate. Solitary life, in that that mating needs to be as productive as possible. So they have very rough mating, they're induced to ovulate, and hopefully then that mating is a productive thing. The other way they come out of season is, which we've seen in captivity and is now fortunately a very, very rare occurrence, is if they stay in season with very, very high estrogen levels for long enough, they will get an aplastic anemia. So again, this is the thing they face. To attract males in, they are very pheromonal. Males have a lot of pheromones, females have a lot of pheromones, hence the smell, hence the stickiness and everything else along with them. And that's a picture of a gill in season with very swollen vulva, reflecting immensely high estrogen levels. And you can see the stickiness of a fur, which is where you've got secretions and the pheromone production coming from. Okay, adrenal disease, first of all, is not Cushing's disease. You often see it referred to as this. It is not Cushing's. The one hormone that is not raised, and this is cortisol, accepted by chance if we're a bit stressed. We can call it adrenal gland disease, we can call it hyperadrenocorticism, we can call it adrenal tumours. The latter not always true, because although they can become tumorous, they are often hyperplastic, usually hyperplastic to begin with. So why do we see so many? This has been many causes mooted for this. Part of it is actually simple longevity. When I qualified back in a different millennium, the average lifespan for ferrets we saw was around about 2 years. They were fed on bread and milk, they had an appalling diet, and they were kept in interesting conditions, and most of them were working ferrets. Now we see more ferrets for different reasons. Obviously, we see pet ferrets, we see racing ferrets, we see show ferrets. They have a much better diet, but prepared diets really have helped with that.
John, just wanted to butt in. You're just fading in and out again. I don't know if you're moving away from the microphone.
Okay, is that clearer?
Yeah, I don't know if are you wearing a headset?
I am.
Yeah, just if you bring the microphone close to, and I'm not sure what you're doing, but you are coming in and then fading out a little bit.
I'm sorry.
That's no problem. Okay. Thank you.
Okay, no worries. Let me know if I fade again. So again, maybe longevity. So now we see average length of time, lifespan for ferrets of being around about 7-8 years. So just living that long is a good cause of tumours of any kind. So it may just be an effect of that. Husbandry has been proposed. We see more ferrets living indoors these days, so it might be effect of light cycles and things, and that alteration of how that basic breeding cycle goes. Diet as well, and it's been proposed that the diet might do this due to some extraneous ingredient, especially in prepared diets. Although, of course, if improved diet leads to increased lifespan, that may be a reason in its own right. However, the big reason that has come through, and the work of Nico Schumacher from Utrecht University has shown that really, fundamentally, the big problem is due to surgical neutering. Now, how does that happen? This is down to the hormone cascade. So we know increasing day length leads to reduced melatonin. That leads to an increase in GnRH production, and that will lead to an increase in FSH, and particularly LH, luteinizing hormone. That will then act on the gonads to increase the gonadal hormones. And then there'll be a negative feedback mechanism where high levels of gonadal hormones will reduce the output, particularly of LH, and so the whole thing will regulate itself that way. Now let's take away the gonads. That's what we do when we do surgical neutering. We take away gonads, and we take away that negative feedback. So what happens is the LH surges are larger and longer, and the adrenal cells have receptors for these. So as a result, they act on them, and they basically, the adrenal cells are overstimulated. This leads to hypertrophy, and then after constant stimulation will lead to tumor formation. These initially seem to be benign and then become malignant from there. The situation will change at some point during the disease process when the adrenal cells gain a degree of autonomy. They start acting away from the hormone cascade. So wherever the LH is, these things just start to grow. And particularly once they reach a tumor stage, this will definitely be seen. And this is relevant, and we start talking about treatments and things, because at this point, treatments that work on the hormone cascade will no longer have any effect. So does timing neutering have an effect? And many people talk about how it's linked to early neutering. And this is relevant because for a long time, a lot of us proposed early neutering, very early neutering. Now, this is not the same as in the States. And in the States, most ferrets come from one producer. They're usually neutered about 8 weeks old. In the UK, we meant by early neutering was generally about 2 or 3 months old, and generally the first autumn, rather than what we were traditionally done, which was in the first spring, so a year after they were born. It does appear that timing neutering does not cause adrenal disease, but from Schumacher's work, it's a very straight line relationship between when they're neutered and when they develop adrenal disease. So the earlier you neuter, the earlier you'll see adrenal disease, but it won't cause it per se. In terms of diagnosis, we'll go through this, and there are a number of ways of doing this. It is actually one of the easier ones to diagnose, and that's quite fortunate, and it's very nice. We can often do this on clinical signs, which for a clinician is always a good way of being. So how do they present? 2 years plus. So if any ferret over 2 years old is a candidate for this. They are always neutered. I've never yet found this in an unneutered, in an entire animal, and both male and female represented. And when we see signs similar to adrenal disease in entire ferrets, we'll look for different causes. And this may well be things like gonadal tumors. And we've certainly had 3 or 4 ovarian tumor cases in the last few years, and they look absolutely like adrenal cases. It's not surprising because you've got an estrogen-producing tumor. Unsurprisingly, looks like an estrogen-producing adrenal gland. Okay, clinical signs. Hair loss is the big one. And the ferrets typically go pretty bald, and that's the number one thing. This may be continuous, where they just lose hair and lose hair and lose hair and lose hair, or it may be cyclical. And very often it seems to be cyclical at the beginning of its disease process. And we'll talk a little bit about rat tail, which is a disease of entire ferrets in a moment. And then it becomes more continuous as it goes on. Oddly, about 25% of these are paritic. Doesn't seem to be linked to a secondary pyoderma or anything like that. But really, when we think about hormonal problems in cats and dogs, we don't think about pruritus as being a problem. In fact, very much as one of those diagnostic things, you'd think of it the exact opposite. But in ferrets, just because paritic does not mean it's hormonal. In fact, it may well make it more likely to be so. They may show weight loss, and certainly in advanced stages, they will lose a lot of weight and become really quite unwell with it. And I've had one ferret this year where actually the only sign was weight loss with a bit of hair loss. Time of year is important. Again, we're talking about rat tail, and often this does seem to be predominantly an autumn diagnosis, although we do see more cases in spring as well. So autumn most common, spring second most. Summer and winter is quite unusual, and this has been going on for a long time. Again, distinguish that timing between when it starts versus when you see it. Polyuria, polydipsia isn't really a factor. Again, getting us away from adrenal thing. Sometimes we may see skin thinning, but I think probably more often we even see skin thickening, which may be linked to hormonal things. And we'll also see hormone-linked signs. So we see the swelling of the vulva in the females with high estrogen levels. We'll also see large prostate in males, and a presentation can be of all ferret with dysuria. And here's at surgery, we can see the size of a prostate here. And again, on ultrasound, you can see the enlarged prostate, which will block onto the urethra and cause problems. And again, care needed with treatment of these. So the hair loss is a big factor. Typically, you start over the tail and the hindquarters and then move over the rest of the body. Again, typically you start with loss of the underfur, and then the guard hairs will go later on. This is a typical very bald tail with the more advanced disease. So you see little comedomes, some of see papules forming, and that can be quite common. So the comedome is quite a feature. Again, you notice on this tail the complete absence of any underfur. Does progress, and they get completely bald on the back end. We'll see it moving over the forequarters and sometimes over the face as well in very advanced cases. We do have differential diagnoses, and there are other causes of pruritic alopecia. These can be mange, particularly sarcoptid type mites. We may see pyoderma, and I've seen one case of dermatophytosis with a secondary pyoderma as well. Both cases shown on these pictures are of pyoderma. Interestingly, of unknown cause, and then primary cause, I should say. I seem to get better with antibiotics and go away, so that's sometimes good enough for me. Rat tail is the hormonal disease of entire ferrets. I should talk in a second there. And of course, there are other diseases which may be linked into neutering. And that is, first of all, that we may have an ovarian remnant left behind. And that's a very important differential for the Gilwithis because they'll look absolutely identical. And we may have a cryptorchid. Now, hopefully, anybody castrating a male will declare that there's a testis left behind, or more importantly, will get that testis out and not leave the outside one. But obviously, things can happen sometimes, and may just have the outside one removed. Now, rat tail is a seasonal problem. It's typically hair loss over the tail. This hair loss can again extend over the back end. And it's almost invariably in entire animals. I suspect in a neutered animal that's simply very beginnings of adrenal problems, but it is a hormonal link problem. And the big key with this is that all the hair grows back before winter, and essentially it's a molt that's gone a little bit wrong. So everything's dropped too quickly and it grows back again. And it's very, very cyclical indeed. Animals that do this tend to do it every single year in autumn, and it's quite predictable about what they do. So again, don't misinterpret this as being adrenal problems. And if in doubt, what you do, if the only sign you've got is hair loss, is just wait a couple of months and see whether the fur grows back or not. And this is rat tail. Again, very similar, not quite as extensive in this case, but we've got the loss of the underfur, we've got this exposed, again, comedomes, and just the guard hairs left behind. So if we are suspecting dermatological problems, what we're going to do, we're going to do skin scrapes looking for mites. We're going to do cytology of the skin. We can do hair plucks. We might do fungal cultures looking for those causes I mentioned earlier. And sometimes, of course, if in doubt, do a biopsy, and that's going to tend to group things more than anything else. And so once those are ruled out, then you can move on. But basically, those signs are really typical. And if you've got a bald, itchy ferret, frankly, it's almost, and it's neutered, or almost invariably going to be adrenal disease. And if it's progressive, it's almost certainly adrenal disease. So we then got to think about looking for the adrenal gland. Now, all of these methods can be used. They're really large. You can palpate them. Obviously, just cranial to the kidney, as we expect from the name. And we can sometimes see them on radiographs, so you've got to be pretty huge for that. And the other way to do it is to find it on ultrasonography. You can be fairly neat with the ultrasound machine, but it's not too difficult. And sometimes you'll just see it. There's a kidney here, here's an adrenal gland there, and you can sometimes see with some differentiating between cortex and medulla as well. And the other way, if you're really not sure, is to actually find the vena cava, because the glands do sit right on that, and then you can find the gland sitting next to it. So you follow the vena cava along until you just find the gland next to there. And finding that gland means it can be measured. You can assess how big it is. You can see whether it's right gland or left gland or both, and it does give you some information before you move on. However, the big deal with all of these, if you don't find the gland, if you can't see it, it does not rule out adrenal disease as a problem. We can do blood. Now, the one thing we'll say is there's very rarely, there's nothing pathognomonic on a general blood profile. So hematology, routine biochemistries can be of use if you're heading towards an operation for us, if you're heading towards a long anesthetic. But certainly, there's nothing on that's going to help you diagnose it. What you can do is you can look for the hormones. And you'll see on various lab offerings, you'll see various different panels being advertised and used for diagnosing adrenal disease. So some people are looking for ACTH, some are looking for cortisol, and I think really those, and especially those offering ACTH stim panels for this, it's not really going to work. Why? Because it's not Cushing's disease. These are Cushing's disease tests, and cortisol is very, very rarely raised. If it is, it's probably coincidental. It's certainly not that diagnostic. So be careful about using those. There is some evidence suggests that, bizarrely, uric creatine cortisol ratios are shifted in adrenal disease. But whether that's consistent, personally, I wouldn't rely on this as a diagnostic method. It seems very nice and simple. So be very careful. What is used is what's called the Tennessee panel. And this may need some adjustment. The typical Tennessee panel is androstenedione, 17-hydroxyprogesterone, and estradiol, and you measure all three, and a significant elevation in one of those is enough to diagnose it. To some extent, you don't always need it. I mean, basically, you've got a swollen vulva, you know the estradiol levels are going to be raised, because by definition, that's not going to happen unless the estrogen's raised. There's some thought that the 17-hydroxyprogesterone isn't that useful, because it's very rarely, if anything, if ever raised, and that's because it comes from a different pathway to the androstenedione and estradiol. And therefore, there's a bit of a move to replace that with DHEA, it's dihydropiandrosterone. Can't even say it. So DHEA is far simpler to say. And that is a more useful one because it's the precursor to androstenedione on estradiol down the pathway they're produced. So that's much more relevant, given that's the same pathway that's stimulated by the hormones. To my knowledge, that's not yet available in the UK, but probably watch your space and it will be. However, there's a catch in this. These hormones are not consistently raised, and they will be cyclical to some extent. So basically, although the negative feedback is largely switched off, there is some degree of it left behind. So you will get periods when they are at normal level, in spite of the adrenal being overactive and the adrenal disease being in process. Which basically means is you can't use this as a reliable screen. So if you've got consistent signs and the hormones are normal, you really haven't ruled out adrenal disease. Given the fact these panels are remarkably expensive and can take a bit of a while to come back, that does to some extent reduce their value. I must admit, I very rarely use these panels for diagnosis, unless I've gone in looking at adrenals and they look okay to me and I've got the right signs, in which case I might take a blood sample at that stage, really almost a tiebreaker to really give me a bit of help before I do a second surgery. So that's the deal. What do you do if you're taking hormones aren't raised? You're no further forward and you spent a lot of money. The other question too is, how do you distinguish adrenal disease from ovarian remnant or cryptorchidism? And of course, measuring hormone levels is going to be absolutely no help at all with that, because they're all going to have high levels. Vulva swollen, there's high estrogen. Where does it come from? The bloods don't tell you that much. So that's another disadvantage sometimes with taking blood, and that's sometimes you do have to have a direct look and have a check. Now, if you're a neat ultrasonographer, you might be able to find those ovaries. You might be able to do it. If you want to be clever, you can give a shot of prologestone, and if it is an ovarian remnant, you'll take that out of season, you'll make it go away, and that's a diagnostic thing, because an adrenal gland will not go away with prologestone. So that's great. Unfortunately, of course, if you want to go and operate and remove that ovarian remnant, you kind of got to wait for it to come back into season, because finding a remnant can be quite hard, but it's a lot easier if it's got follicles on it and the animal's in season. Of course, the payback is that with lots of estrogen, they don't clot very well, so that can be a little bit more difficult. But if you take it out of season, get rid of the follicles, that ovarian remnant can be really impossible to find. So personally, I tend to operate when they're actually in season. So I don't use prologestone, I don't use chemical means to distinguish, I go and have a look. So I mentioned the hormone levels can be normal, and all of which boils down to how to diagnose. Fundamentally, go and have a look. Do an exploratory. Seems a little invasive for a diagnostic test, but bear in mind you've got very, very suggestive clinical signs. The advantage is you can have a look at both glands. You can actually see how big they are. You've got no false positives there. You're really going to find out what they look like there. It also has therapy, because main therapy for this is surgery. You want to get rid of your adrenal gland that's affected. You want to, we want to progress from there, so that is useful. And of course, you can have a look at other structures. You can look at where the ovary should be, and you can see if there's a remnant. You can check the lymph glands, because actually concurrent lymphoma is quite common. So is concurrent insulinoma. So have a look at the pancreas. And there's various cases written up where all three have been going on at the same time there. Typical ferrets, when they start producing tumours, they will produce tumours everywhere. So have a look around, you get a good picture of what else might be happening with animals. Obviously, disadvantage-wise, it's invasive, it's quite expensive. You might need to prepare the patient for it if it's unwell overall. Although actually ferrets tend to be fairly bomb-proof with anaesthesia, and they're nice, easy patient anaesthetised, and often in these cases there's not too many secondary problems. So preparation is normally fairly simple. The big deal is, what if it's not that? The glands look okay. This is where I do take that blood sample, and I will stitch them up, and if the hormones are raised, then I will go in again and think, okay, fine, I misread that. If they're not raised, then I might start thinking about other diseases that could cause a hair loss. If you go in there and you don't recognize it, that's a problem, because then you've done a big surgery and haven't recognized the problem. So you've got to have good communication with the owner at this point if you haven't found the adrenals or haven't done something. In terms of surgery, fortunately, most cases to begin with, 70% start on the left-hand gland. Why? I've got no idea. That's really great for us, because this is the easy one to remove. There is a space, there's a few millimeters between the gland and the vena cava, and that's what you want to be able to remove. That's enough room to either ligate or to use hemoclips to get in there and get the gland out cleanly. You've got to have a look for the blood supply. Some will have a blood supply from the vena cava. Some will have it from the vena cava aorta. Some will have it from the renal artery and vein. Some will have from both. What is important to recognize, if you get that left gland out and the right gland's normal that time, the predisposing factors are still there. So you will have adrenal disease in the right-hand gland at some stage post-surgery, unless you do something about this. So here's some pictures of the left gland. Here's a kidney. Here's our gland enlarged there, and you can see the vein running into the vena cava. Operating, again, needs to get opening with a cap so you can see the gland lurking beneath the fat or in amongst the fat, again, the kidney behind. The right-hand side is a different matter altogether. It's actually onto the vena cava. And very frequently, you actually get invasive tissue entering the vena cava. So if you're going to operate on this side, you either debulk the gland, in other words, you're automatically leaving tissue behind, and if you're invading the vena cava, it's almost certainly going to be tumorous. Or you have to resect the vena cava and actually take a section out along with the gland. Now, actually, that's okay. Ferrets bizarrely have a collateral blood supply, and that's via the vertebral vein. So what will happen is they'll simply shunt blood flow from the caudal end up through the vertebral vein, so you don't get the problems. If you resected the vena cava in a dog or a cat, you'd be in big trouble. In a ferret, no worries at all, that's fine. The problem they do have, though, is there is a problem with pulmonary hypertension in about 25% of them post-surgery, and the death rate is around about 1 in 4 after surgery. So if this really is essential, you have an invasive tumor into the vena cava, the ferret has signs severe enough that this needs doing, then you've got a problem, because, say, 1 in 4 will die, but you may save 3 in 4 and be able to get that tumor out completely. Ideally, you leave it alone at this point and use some medical means. If both sides are effective, generally what we'll do is we'll remove the left-hand side, we'll debulk the right-hand side, possibly with a view to reoperating later and actually removing the vena cava, but probably not remove both in one go and resect. Post-operatively, the nice thing is no need to supplement any of the adrenal hormones. I really don't know why this is. Even if both glands are affected, presumably there is some accessory tissue somewhere, but even there doesn't appear to be a need to give mineralocorticoids or cortisol. They seem to be able to produce that from somewhere else as well. They will bruise, and this is probably due to the high estrogen levels kicking around. And it's always worth warning owners about this one, because they do look like they've been thoroughly beaten up the day after. And even with clean, easy surgery, they do look pretty dramatic. And the other thing to do is to consider starting medical therapy. And that's if basically you've only removed the left-hand side, or if you've only debulked the right-hand side, in which case you've got to basically protect the rest of the tissue and try and prevent clinical signs occurring. So what do we use? These are all the failed ones. Mitotane, trilestane, ketoconazole have all been used, varying degrees of success, but bear in mind these are drugs for Cushing's, and it's going to basically blast out adrenal cells, and they're almost too heavy. They don't work that well for this particular syndrome, and they do cause side effects. The other ones, obstetric blockers for these hormones, have been used, variable effect. What has been used is used most of the time are GnRH analogues. And the big one of that one is leuprolide acetate, sold over here as Prostap. It's downregulated receptors. It mimics the hormone cascade and resulting in shorter LH surges. It is pretty expensive. It is sold for prostatic problems in people, and it is really expensive. In my hands, this is not very effective. We used it for a long time. I saw very little effect. 1 or 2 cases seemed to hold. We didn't seem to make anything better. Certainly, given how responsive in the United States have been recorded, where they regard it as being a mainstream therapy and very effective one, it didn't appear to be that at all. And for the cost of this drug, and although you could get a single dose syringe for a person, you could freeze it in dose aliquots, and it'll keep for 6 months, and that helped a bit with the cost. It's still very expensive. It wasn't great. So fortunately, Deslorelin's come along. This is a super analog. It's slightly different the way it works to leuprolide, in that it actually induces negative feedback within the cells. That has been much more effective, and we can get rid of signs with this. So when do we use these implants? Well, essentially we're removing only one gland, as mentioned before, and we're using it for prevention. It's really good at preventing problems. Do we use it instead of surgery? And this is often mooted as, if it's that effective, it gets rid of signs so well, and it does, why operate? And the reason is because it doesn't stop the disease process. The glands will carry on growing. So essentially when they break through, that's showing it really is not going to respond anymore, and that's when we have got serious problems at that point. If we can operate, we can remove that left gland and protect the right gland, we've solved the whole problem. It's not going to be a problem in future. If we simply use implants, we're doing it because it's all we've got left. And so that's really, if we've got a right-hand gland, we'll say, okay, this ferret is going to have a problem with that right gland. Got 1 in 4 chance of dying if we operate. It's got problems going to develop. We're going to use an implant to take the signs away and make it feel better. So, and again, only in the early stages. Like I mentioned before, if they've got a stage of autonomy of a tumor, it's not going to work. They will break through. And the other time not to use is if you've got prostatomegaly, because the first thing it does is induce a surge of hormones. Fine if that's the only sign is hair loss, because you get a bit more hair loss, doesn't really matter. It's going to, in 2 weeks, it'll switch off, and the negative feedback in the cells will start to work, and then you'll get a drop in hormones and everything will be great. But that 2 weeks of prostatic extra enlargement may be enough to turn dysuria into complete blockage of urethra. And I have done this when I've been seen a large prostate. I've operated on the left gland. I've put an implant in place at surgery. I've seen real problems. I had hell to manage the prostate after that. So be very careful indeed. And in those cases, I'd probably recommend using ipazane, which does seem to be very effective in controlling a prostate before moving on. So that's roughly how to treat it. How about actually preventing it? Well, I mentioned about later neutering, and maybe that's going to postpone it late enough before it occurs after they get their other problems. But there are alternative surgical neutering, both Gills and Hobbs. And of course, this again is where the Desloreline implants really come into their own. They're very useful indeed. Which we use, the 9.4 milligram implant is licensed in male ferrets only. It's licensed for a year because the trials have gone on for with that. However, the 4.7 milligram implant has been used for a long time. It's used in the field for a long time, and there's great experience based on this. And most of the publications have been based on using this. So my experiences I'm going to relate now are based on the 4.7 milligram implant, i.e. the unlicensed one. Which do you use? Well, again, it depends on how you feel. And clinical experience does mean that you can bypass the cascade to some extent, but in true interpretation of cascade, you probably should use a 9.4 in males. In Gills, they're both off license. That's up to you entirely. You insert these under the skin between the shoulder blades. For the 9.4, it's in the data sheet that you should anesthetize. For 4.7, a lot of people do that with anesthetic. A lot of people do it without anesthetic. I tend not to. Maybe for a long time I was using prologestone, which is very painful, and actually even a large implant is less painful than that injection. In 4.7s in my hands last 18 to 24 months. And if you do it in spring, because then as it's wearing off, you tend to get that drop occurring as the daylight takes them out of season anyway, so you definitely get 24 months. In some cases, I've seen it last for over 3 years. A paper in the Vet Record produced a few years ago suggested maybe it should be recommended at 12 monthly intervals, because there were a few outriders that occur, that came in season after less than 18 months. But in my experience, that's really quite rare, and we tend to tell owners to watch out and come back earlier if need be. So it is a bit of a role about when they're implanted in a year, and certainly I tend to recommend people coming in spring so they get better value. They're rapidly effective, but the big deal is that for the first 2 weeks, they become more hormonal. You get a big surge of hormones. So males become more smelly, they get bigger, they get a bit more aggressive. The females come right into season, and even if they're out of season when you give the implant, they will come into season. And it's a potentially fertile season too. So you've got to be careful to separate males and females during this period. On 2 weeks after implanting, almost to a day, they will go out of season. If they don't, that means that sometimes little deers have groomed the implant out of themselves, so it's worth checking and making sure that's not what's happened. But on 2 weeks, they'll go out of season. The males lose their smell, the testis size shrinks, their behavior and everything else becomes just like they've been castrated, and the gills will go out of season, the same deal. And it's very effective then for a long period of time. We ask questions by owners. The implant is resorbed, so you don't get a build-up in many lumps of implant over time. They actually do seem to dissolve and go away. In dogs, they have been shown to be safe at 10 times overdose, so using a whole implant in a ferret doesn't seem to matter either. They don't seem to track much, but you'll be very careful when you're inserting them. They don't follow the needle back, a bit like microchips can do sometimes. And I used to use my thumb just to move them around a bit so we don't align with the hole that easily to reduce grooming out. Always look back for signs coming back into season, especially with mixed groups, because you are going to get a few outriders occasionally. It's worth checking that. And we tend to recommend regular implants. Now, surgery, we do 2-year recalls, and that seems to be working well for after a number of years. Cost-wise, this is one of the other factors that people may have problems with. It is more expensive than surgical neutering, but there are health benefits to this, and it's a matter of communication about how you relay this and what the uptake is. An alternative for a Jill is that there is this thing called Jill jab. This is prologestone, and the dose is 0.5 ml of delvostrone, and that's given subcutaneously. It is very painful. They do shriek a bit. It can lead to pyometra in very rare occasions, being a progestogen, but it's quite unusual, and we sometimes get skin reactions, which are more common. It is licensed in the Jill, so technically according to Cascade, you should use this before you use an implant, but there are potential other health benefits of the implant over the delvostrone. Recently, or the last few years, the product license changed that delvostrone is now only licensed to be used and discarded within 24 hours of opening. So you do need to get a group of ferrets together, and this is why it tends to be used for club evenings. So we get all the ferrets in a club together, and we give them all their Jill jab same night to justify use of a bottle. Otherwise, it's a very, very expensive treatment for a single ferret, because it comes in 20 ml bottles. However, it is effective. Timing is very variable. Some years, one jab will last them through a whole year. Other years, depending on the way the light cycles increase and decrease and how good the British summer is, then we'll find that they will come back in season several times. You need several Jill jabs to keep them out of season. Sometimes you may need spay for other disease purposes, so like pyometra, tumours, that sort of thing. For the hobs, for males, again, we can implant them. Some people have a vasectomized hob. We call it a teaser hob, and certainly for working people, then they will often have one of these, which is a much cheaper way of keeping the gills out of season. So you let him mate the gills, and obviously you then get a non-fertile mating, which brings the gills out of season. Got to be a little bit careful because, as I said, it's very rough mating. They chew your gills around the back of the neck. So by the end of the season, the gills are often bald on the back of the neck with chew marks all over them because they've been mated several times through the whole year. So for show people, for pet people, it's probably unacceptable. And of course, the hob is a full male. It's very smelly. It's very big. It can be quite aggressive. And certainly in the pet world, that's probably not a satisfactory creature to be keeping. And of course, surgical castration, again, can be used for different reasons. Tumours do occur. We've had epididymal cysts post-vasectomy, it may occur as well. Other questions, lots of ferrets are neutered ferrets are out there already. Should they be implanted? Because obviously they're at high risk of adrenal disease. And the answer is yes, they can be. We will recommend this to people that they've already had the ferret neutered, surgically neutered, or if got one from a rescue place is surgically neutered. If they implant that with a renewal every 2 years, that's a really good way of controlling and preventing adrenal disease. And of course, is there a place for surgical neutering? Well, actually, yes, there is. And we still see a lot of ferrets coming in from rescue places. And of course, in rescue, the big priority is to make sure that those animals are not going to breed, because that's the problem that they're trying to control. So surgical neutering of dump is overall the cheapest way of doing this and controlling this. And again, for some owners, they can't afford the implants, they can't afford problems. Now, there's a question about should they be keeping ferrets, but nonetheless, like all things in veterinary medicine, it's our job to inform. And once the owner has information, they can make informed consent as to whether they go for implants, whether they go for some other chemical means of birth control, or whether they go for surgical neutering. And then largely it's up to them. And it's not guaranteed that if they're surgically neutered, they will get adrenal. That certainly doesn't happen in every case. It's an increased likelihood, though. And the final take-home message is that this is the exception to the rule, but lots of people phone us about ferret problems and say, what do I do? My usual response is, and this is a line taken from a lecture by Rebecca Stepien, who gave a wonderful lecture on ferret cardiology, is a ferret is a cat that looks like a weasel. So if you're seeing a ferret, you have a problem case, then treat it like you would treat a cat, and you'll very rarely be that far wrong. Thank you.
That's great, John. Thank you so much for that. I've got, just while people are having to think of questions, I've just got a couple of slides to show. So I need to just get those up. There we are. It's hiding in the corner. I know we've got quite a few of the Diamond members in tonight. So I just wanted to let you know about the virtual congress that's coming up, and I've just got to share my screen, so let me do that screen, and you should be able to see, just see if I've got this right, you should be able to see the just introducing the 5th virtual congress. Can you see that okay, John?
I can.
Great, okay, so just very quickly, while people are having a little think of questions, just introducing the 5th virtual congress, which all the Diamond guys will get for free. If you're listening in, you're not Diamond, then we can obviously still let you have a ticket as well. So on the Friday, it's Association Day. We're going to have BVA and the Royal College, and if you're a BVA member, in fact, you would get the Friday free anyway. And then the evening time is the Resilience Day, and that's available for anybody in practice. So the morning is BVA Day. If you're a BVA member, you get that for free. It's dermatology and welfare. Free for all members. You just have to have your membership number, and you can actually sign up for that using those URLs, which Catherine can take and put into the chat box so that you can use. And if you are going to the conference, either as a Diamond member or, you know, somebody else who's going to go to the BVA part or to the whole conference, do, if you are on Facebook, just say that you're going to the event, which is the virtual congress event on Facebook, and, you know, feel free to ask, invite your friends as well. So Catherine, no doubt, is copying that at the moment. So we'll give her a few seconds so she can just put those details down into the chat box. On the Friday night, we've this year we had a happiness symposium. Next January, it's going to be a resilience symposium. We've got Eleanor O'Connor, Jenny Moffat, and Mike Scanlon, all very good speakers, and we can send you the URL for that. The actual Congress-a-thon takes place all day Saturday, midnight to midnight. Everything is recorded, so you can watch at your leisure, but of course we'd love you to be there on the day. And these are the various streams, so a good selection of topics that people can look at. In fact, the Exotics Clin Path is being done by Nick Carmichael and John. So looking forward, obviously, to hearing John again. You're talking how to collect samples in that, I think, aren't you, John?
That's right, yeah.
And then you and Nick will no doubt be chatting about how to interpret them, because they are obviously quite different from dog and cat.
Probably disagreeing about the many uncertainties on interpretation.
Yes, yeah, which is always good fun. If there are two vets in a room and they both agree with each other, one of them is not a vet.
Or one hasn't been listening is the other one.
Yeah. So again, here's all the speakers. We've got some great names there, and I think it's going to be a great conference. I mean, basically, if you are interested in doing that, if you're a Diamond member, you will be able to come anyway. If you are another person who's listening in at the moment, what we can do at the moment, we are selling these tickets for $197 plus VAT, unless you're a BVA member, in which case they're half the sort of top price, which is $173.50. And Catherine can, I think, put the URL for today in the box, so you'll be able to buy that. Once the 30th of November comes, the prices are going up. But for those people who are on, we've also got some bonuses. So at the moment, we are in fact including as free bonuses the recordings of the mindfulness series. We're also including our GI expertise series, which was chaired by Jane Armstrong, Professor Jane Armstrong from Minnesota University. And so that should be a fantastic, that is a fantastic series. I went to most of those webinars and obviously love gastroenterology anyway, but it was a fascinating series, and I'm sure you would learn a lot from going to that. And these are bonuses that you'll get immediately, so you can watch those whilst you're awaiting the actual live conference to happen on the 20th and 21st. And then finally, for those of you who buy within the next couple of days, you'll also get the recordings of our first ever virtual congress, which was in 2013. So do have a look at that. If there are any doubts, you're not sure of anything, you can always email Megan, MEGAN, at thewebinarvet.com, and she'll be able to go into more detail with you. But I don't know, Catherine, if you've managed to find the most up-to-date, that kind of URL that we've been using. I think it might be VC17. So I think if you put VC17 on the end of the URL and you buy your ticket in the next day or two, we'll make sure that you get those added benefits as well. So Catherine will put those in while we're waiting for questions to come up. So I think we have got a few questions. Maria is asking, can a Deslorelin implant be used? And I know some of these you've possibly asked, but I think it's always good to go over them again. Can a Deslorelin implant be used before we have an adrenal problem? Like when a ferret was neutered at 1 year, at 2 years, we put the implant as a prevention, or will the adrenal still break through?
We use them as preventive, and they seem to be okay. And Nico Schumacher's work seems to show a very effective preventive. So they do seem to be pretty good.
So it's worth doing that.
Yeah.
You also talked about, and I must admit I just missed it, you were talking about the ferret having all sorts of tumours. So it gets the adrenal problem, it gets an insulinoma, Was the other one a lymphoma?
Lymphoma, yeah, lymphoproliferative,
Yeah.
really common in ferrets.
So you might see all three of those together?
Yeah, you really can, and that's why I like exploratories, because you get a chance to look at everything, and that gives a much more accurate prognosis about what's going on and things. So you can really have a good evaluation while you're in there.
That's really bizarre, isn't it?
They are little tumor factories when they put them on.
Yeah.
Again,
Do we kind of know why that happens? I mean, obviously I can understand the adrenal thing. Do we know what triggers what, or are they working independently? Or
yeah, they seem to be very independent. Now the pancreatic does appear to be very largely linked to dietary carbohydrate levels and sort of long-term overstimulation with carbs, and that's a function of probably of poor diet. Lymphoma, hard to say, probably genetic. I think it's quite important. Studies done on ferret diversity show that really there isn't genetic diversity.
Yes.
They're fundamentally from a very, very small stock originally. So that was first done in the States, and everybody's not the least bit surprised. They all come from one producer. But then when it's been repeated internationally, there's still very, very little diversity. The only time it seems to come across is we got some tested which were half wild polecat, and they had a little bit more in them. But yeah, it's probably genetic factors, and that could go for all three tumours as well.
Yeah, no, that's fascinating. I mean, when you're talking about the carbohydrate diet, is that a particular diet that a lot of people feed? What sort of diets do people feed their ferrets, and do they be very sort of cereally based, or? Well,
they shouldn't be. Most are feeding prepared diets and whatever. And I think the important thing when you look for the ideal diet is it should be very high in protein, it should be high in fat, it should be negligible in carbohydrate, and definitely negligible in fiber. They don't work on that at all. They have a very rapid gut transit. They're obligate carnivores, and they do need that high protein, high fat.
So low fiber and low carbo as well.
Yeah. Ultra cats, they're like cats, but more so.
Real, as you say, an obligate carnivore. Katrina's saying, thank you, John. Unfortunately, I got called out in the middle, so thank goodness for webinar vet recordings. I absolutely agree. You're absolutely right there. So Maria, I think, is wanting to ask a few more questions. So we'll just go through those while other people are thinking or just listening. When the adrenal glands are affected, does cortisol hormone levels get higher, just like in humans, dogs, and cats?
No, it doesn't. No, and that's why measuring cortisol really is ineffective.
Yeah, you were talking about that, weren't you? So it's not, as you were saying, it's not Cushing's disease, is it?
It's not Cushing's, definitely not.
And this is why you go for the Tennessee panel.
Yeah.
We're then in this position where you're probably going to start calling this ferret disease alopecia X, which means we really don't have a clue what's going on.
Exactly. The mechanism of pruritus really is not explained.
No, that's an interesting one, isn't it? So the only thing you would wonder with some adrenal, again, Cushingoid dogs, they get calcium secreted into the skin, which I think can cause irritation. But
haven't seen
interestingly, I used to see occasional hypothyroid cats that were itchy.
Yeah.
Almost not itchy, but it was almost like a behavioural pulling at hair and things. So, yeah, no, it's interesting, isn't it? Maria is asking another question, so we'll just carry on because they're all good questions. Is there any statistics about the adrenal gland tumours in not neutered ferrets, or is that supposed to be seen only as a rare case?
To be honest, I've never seen one in an entire ferret, and they're not really described. The ones I've seen have been linked to gonadal tumours, and if you think about the mechanism, it really shouldn't be possible in an entire ferret. Now, that said, any organ can become tumorous for just on chance, what other factors may be. So imagine extremely rarely it is possible to have adrenal tumours in an entire ferret, but through a different mechanism. But
yeah,
all
you can
intents
certainly have adrenal tumours in a non-intact dog or cat, can't you?
Yeah,
you
exactly.
Can have an intact one as well.
Yeah, but whether they're going to be tumours of the same cell lines, really unlikely. So, it's going to be a different type of thing altogether. So I think for our purposes, regard it as being rare to non-existent.
Yeah, no, that's great. Maria's last question, can an insulinoma make the implant last not as long as it should? These two diseases seem to be connected. We had a case when a ferret with insulinoma developed adrenal. The implant lasted only for 6 months. Since the implant since the implantation, then the hormone levels got up again?
Really not. I mean, basically, insulin is going to make the whole metabolism go horribly wrong, and may have more impact on life expectancy than anything else. In terms of the implant, they will break through anyway. Eventually, those adrenal tumors will break through. The hormone, the implant does not prevent development of the adrenal gland. It only masks the signs. So if they've already got a tumor there, eventually that will come through.
So you don't think the insulinoma hasn't been significant there?
That's due to the adrenal gland itself breaking through, not due to the insulinoma.
And the adrenal gland can break through at different times, basically.
Yeah.
And the insulinoma is obviously, it's a functional tumor, but it's not a metastatic tumor as such, so it doesn't cause.
They can metastasize. Some are. We've had some going to livers and stuff. Yeah, definitely.
But by the name is more benign than malignant, presumably.
Yeah, most are benign.
Yeah. Maria, just interested to where you're listening in from, if you want to tap that in. Obviously, has anybody else got any questions? Feel free. John will be going shortly, so if there are any questions, please do feel free to pipe up. I'm not sure at the moment if those URLs have gone through, so if you're in doubt, by all means, just email Megan. If you are a Diamond member, you will get a free ticket for the virtual Congress. If you're not a Diamond member, want to know what that is, email Megan. If you just want to get a virtual Congress ticket, if you email Megan at thewebinarvet.com, she can get back to you and sort you out with a ticket before the price rises, and make sure that you still get those bonuses that are available. Really only to London Vet Show, but because you're on the webinar, I'm happy to offer that to you.
There is a question on the chat, though.
We've got another one, Bev. Yeah.
So
right. There's a chat. Let me look for the chat one. Yeah. Okay. This is Bev. Right. I can read that one out if you like. I think she put it in both places. Bev said, how commonly do you see adrenal gland disease? Anecdotally, it seems to be a lot less common than the American literature suggests. Also, are you aware of any successful cases where people have manipulated photoperiod as a management method?
Okay, the second part, first of all, no, I haven't seen that, and it'll be interesting to see how that goes. And people are beginning, in the States, beginning to use melatonin implants with apparently some degree of success, but again, no personal knowledge of that.
Yeah.
It is pretty common, and we will see at least a dozen cases a year. Some people suggesting maybe getting less common, but I haven't seen that yet. There may be something to do with the implants being under control. I think it's probably more effective the more vets are dealing with ferrets, and more vets are treating adrenal disease rather than going to exotics people. But actually, it is pretty common. If any reduction compared to American literature is because we don't neuter so early. So, of course, their ferrets get adrenal before all the other problems manifest.
Sounds very similar to seasonal flank alopecia in dogs. Obviously, they don't have the adrenal tumors, but obviously responds to melatonin, and also you have that kind of panel that we use, which we've kind of gone through that, spent clients' money looking at it, and then realised that there doesn't seem to be really any trends. They can be anywhere they want to be, and it's a bit difficult to really make any sense of them. But that was just me. You probably, being much cleverer, would have got more sense out of it than I did, John.
Out it.
So the final question is, and Bev, don't apologise. There's certainly no technical ineptitudes there. They're all brilliant questions, and hopefully you've not been struggling getting on the webinar. And then somebody else has asked, what time do you recommend to do the later neutering of ferrets? So in your practice, when are you neutering ferrets?
If I do surgical neutering, I do it in the first spring. So in other words, ferrets who are nearly a year old. So they're usually born in late spring, early summer. They go through that. Sometimes they come into season in the autumn, but we won't neuter until they've gone through winter, gone quiet, and then they come into season again. So I do actually love them in season before I do it. And if it's a Jill, then I'll bring them out of season with prologestone before I operate.
Great. Okay. So just a final one. It'd be interesting to hear where you're from, Maria, if you can tell us, are you listening in from the UK, or are you listening in from further afield? But Katrina said, frustratingly, some of my ferret textbooks saying almost nothing about repro neutering problems. It just says they are all neutered before leaving the breeder. Must be a US edition.
Yep, exactly that. There is a new textbook available, actually, only come out last month, which is from Kathy Johnson Delaney with Ferret Medicine and Surgery, published by CRC, and I've contributed to that. But that's been an international thing, or Anglo-American primarily, with Dutch input from Nico Schumacher, and that really is as up to date. The textbook is going to be as up to date textbook can be, really, and it looks pretty good. That's just been published, and that does have all those sort of things in there because it's gone international with different ways of managing and stuff.
Brilliant. So thank you so much, John. That's been absolutely excellent. Really enjoyed that. I think ferrets are such fascinating little creatures, aren't they, and becoming more popular. I was amazed. I think a few years ago you did a webinar for us as a lunch and learn for a company who might make some of those products that you're talking about. And I was really sort of dreading that we would get very small numbers. And at a lunch and learn, it was a number of years ago, I was amazed when we had 500 vets and nurses listening in. So obviously a popular little pet as well. And, provided they don't gnaw your fingers off, I think they're a friendly little thing as well, aren't they, on the whole? As I remember Richard Whitley saying, or the man saying to Richard Whitley, he's only playing with you. If he meant it, he'd be through to the bone by now.
About the strength of it.
Yeah. So thanks again, John. Thanks everyone for listening. Diamond guys, obviously we will make sure that your tickets come across to you. But, do go over to the website, theinternationalwebinarvet.com, if you do want to kind of peruse the timetable in more detail. And we hope to see many of you at the virtual congress listening to John again, 20th and 21st of January next year. Thanks very much, everyone, and speak to you soon. Bye-bye.
Good night.